Welcome. Thank you very much for coming. My name is Scott Reynolds, and we're very excited to be here. Luke Whalen, our CEO, Dr. Wade McKenna, our Chief Medical Director, Zach Collins, our Quality Assurance Manager and Design Engineer, Jeff Revis, our Sales Manager, Jen Coble, our Account Manager, and a few other people that are associated with our company. We have Brian Barnes, we have Kyle Webb, and we have Jen Smith. This afternoon, Dr. McKenna is going to give you a presentation on the clinical usage of bone marrow aspirate concentrate in the surgical arena. And hopefully you'll find this very interesting. We are the manufacturer of what we call the Biomac bone marrow aspiration cannula that is, in our opinion, a much better way of aspirating marrow when compared to the Jamshidi. So you'll hear and see a lot of information about that this afternoon. And then following this presentation, Jen Smith from our Arterio side will be doing the instruction on how to run our biospin centrifuge in Classroom C. With that, I'd like to introduce Dr. Wade McKenna.
This is absolutely the coolest time I've ever given one of these lectures because I got to wear scrubs. As an orthopedic surgeon, I'm not a tie person. You guys are used to working with more corporate medicine, and I'm in private practice in the middle of nowhere, and I get to do pretty much whatever I want. So I never wear a tie ever. This is we're gonna try to get some of the basic sciences of what we're doing, but more of just the clinical experience. I have about 5,000 stem cell cases over the last 6 years. The science behind bone marrow, I have very unique access to tissue bank and flow cytometry and electron microscopy. And for a private practice orthopedic surgeon, Dr. Neil Reardon is my partner, who's one of the founders of modern stem cell theory and thought. And so we've had a very unique opportunity to do cell counts on a lot of draws to be able to see the difference from one draw to another, to be able to get a real experience on cell count differences from proximal humeral draws to calcaneal draws to iliac crest draws from one side to the other. And I think what I'm going to try to do is give you just a little bit of clinical information that I think there's a lot of misunderstanding about what we're doing. I think that when you kind of see kind of and you have to leave it to an orthopedic surgeon to simplify everything, right? But I think when you see a very simplistic view of kind of the science behind what we're doing, there'll be a light in the tunnel kind of moment for most of you where it kind of clicks that what we're really trying to do for people. This is every stem cell lecture you're ever going to go to. This is what they're going to talk about. So I'm not going to talk about any of that. So if we're not going to talk about the pluripotential nature of the cell, basically when you hear someone talk about the pluripotential nature of the cell, oh, it can become these other 6 cells and these 6 cell lines become, that's not, technically speaking, that's just not how it works. These cells do differentiate, these cells do become other cells, but the magic of what we're doing, the decrease in healing time, the lower infection rates, the chondrogenesis, the cartilaginous responses, the tenogenesis, the myogenesis, the angiogenesis, the difference in blood supply you see to your wounds is from what these cells secrete. It's the secretome of these cells. And there's 2,000 different proteins and peptides we've been able to isolate, and it's what these cells secrete that make the difference, not what these cells become. These cells don't become anything other than what they are. Some of them will differentiate and become cartilage. Some of them will travel around the body and go back to the iliac crest and then come back into the knee. And we've tracked all that. Most important function of the cells is what they secrete. Okay, so we're going to try to change some of the thinking of we're putting stem cells there to become cartilage. That's not really true. The guys that do that are on a very unsophisticated level of what we're trying to do. We're not creating some patch of cells to become, well, how do you keep them where they want to go? Well, we're not trying to keep them where we want to go. We're trying to provoke a healing response by the human body that is already possible, but for some reason as we age, we lose the ability to do that. Little children, when we do these big OCD lesions in kids, or when you see a big transcondylar fracture in a kid, they will grow new cartilage and heal that wound. Little bitty femurs become great big femurs. Chondrogenesis is possible in the human body, right? For some reason, as we get older, we lose the ability for chondrogenesis. And the reason we lose that ability is the stem cell count subchondral drops to almost nothing, and there's no way to provoke that response. We can't flip the light switch. What we're trying to do is just flip the light switch. We're trying to change the angiogenic response to the knee or the angiogenic response to the tendon. So we're not going to talk about the differentiation and the cell lines. I hate that slide. Everyone has that slide where you see one cell and the 5 lines and it becomes all this stuff. We are going to talk a little bit about angiogenesis and what we're talking about. Biologic therapies. Just as a company where we're going, we started with PRP. PRP is a way to pay the bills because blood had approval and bone marrow didn't. The vet market is what provided the way for a lot of the research it has now. PRP, if PRP makes a difference at all, bone marrow is better. The growth factors that you isolate from PRP, bone marrow is 97% whole blood, okay? So the one thing I need you all to understand is that the only difference between bone marrow and a peripheral blood draw is stem cell count, right? Mesenchymal stem cells, CD34s. And the difference between bone marrow and fat is CD34s because we have hematopoietic stem cells, right? So without hematopoietic stem cells, there is no angiogenesis. Without angiogenesis, there's no healing of a tendon, there's no growth of cartilage, there's no healing of a wound, okay? Bone marrow isn't just about MSCs. This is the point I try to make all the time when people talk about bone marrow and the difference between PRP. And I've actually gotten in an argument on the fact that PRP still has a place and PRP is better. And the best argument that there is that even the guys doing it in the trenches, the surgeons, don't really understand what we're doing is this paper out of Israel that I referenced at the bottom. And basically what they did is they took complex tibia fractures and they squirted bone marrow and PRP in half of them, and half of them they treated with the same operative treatments but without bone marrow PRP, and they changed the healing time by over 50% and the patients treated with bone marrow PRP. But using bone marrow and PRP is kind of redundant, right? When you're using bone marrow, you have PRP. You're spinning down whole blood just with higher cell counts. You're getting all the advantages of PRP, and actually you're getting better PRP from bone marrow than you get PRP from whole blood. Does that make sense? If PRP is just platelet-rich plasma, what we're talking about is about 15 concentrated growth factors. VEGF, fibroblastic growth factor. We're talking about basically about a core group of about 15, right? If we can concentrate those down in whole blood, you still don't have CD34s, you don't have any really mononucleated mesenchymal stem cells, you don't have a hematopoietic stem cell, you don't have CD79s, 101s, 34, you don't have any of those stem cells that we're really looking for. You have growth factors, and you have a one-time shot. What you give that patient with PRP is all the growth factors you're ever gonna have. When you give a bone marrow shot, that's not all the growth factors you ever have. Those cells are metabolically active for months, right? So, but even the guys doing it are still adding PRP to bone marrow. And sometimes you do it to expand your count. Look, if you can't get much bone marrow, there are times where I'll spin down some whole blood with it. But it's uncommon to not get much bone marrow. And if someone's paying for it, I'll draw in another location. You know, it's their kit. They're paying the price. They came to me for a stem cell surgery, and just because I didn't get enough out of the tibia doesn't mean I'm not going to go to the iliac crest. If I don't get enough out of one side of the iliac crest, I'll draw the other, okay? What we're talking about, and this is what we're trying, the point I want to drive home today is biologic amplification or biologic augmentation. All the different problems in orthopedics, general surgery, really surgery as a whole, just even physical medicine, even in a clinical setting in an office practice. There are certain illnesses and injuries that the body just lacks the ability to get over the hump. You get a chronic tendinitis, and it can be disabling. Even lateral epicondylitis can remove people from the workforce. I mean, it's just a tennis elbow, right? But they've had surgery, they've had steroids, they've been through therapy, and they still can't even make a fist with or pull with their arm out straight. That person's never going to be a wire stripper at General Motors again, right? Non-unions, the body's great inability to heal a scaphoid fracture or a clavicle or some tibias. All we want to do is help the body over the hump with some of these processes. Degenerative joint disease is the body's inability to heal a cartilaginous lesion, right? Degenerative joint disease is fretting. Cartilage frets. It doesn't dissolve. You get little wear debris. Wear debris accelerates a pattern. You do get dissolution of the cartilage because of that. All we want to do is help the body over those little humps in healing that it just needs something extra with. It needs these concentrated growth factors that, because it's lost the ability to produce them in the same levels as it did when you were little, it can't heal like you did when you were a kid. You don't see chronic Achilles tendonitis in a 12-year-old, right? You don't see dramatic lateral condylitis in some 10-year-old kid that's, playing baseball, right? The previous goals, when we first started doing this is 6 years ago, all we were trying to do is provoke some curiosity, see if I could get people thinking about problems that existed in medicine and ways to help kind of achieve a little bit different result with those problems. That's not our goal anymore. We're 5,000 cases down the road from that as a goal. What we're trying to do now is shorten your recovery time from traditional surgeries, lower their morbidity and failure rates, the invasiveness of the procedure. What I tell people all the time is the goal of bone marrow support concentrate and amniotic product and the autologous stem cell products that we use is to take great big surgeries and make them smaller, take smaller surgeries and turn them into a shot, and take all surgeries that have some kind of a failure rate and lower that. Okay, so that's the goal of what we're trying to talk about when we talk about biologic augmentation or amplification. The key little things that we treat, and obviously the clinical application list has grown quite a bit over the last 5 years. Lateral condylitis, look, if you're still injecting steroid in a tendon, you need to read. Fabini, I mean, there's 50 articles out there that show that if you inject, and it makes no sense. Everyone here knows that steroids are an atrophitic agent, right? They destroy and dehydrate proteins, they destroy tissue, they cause avascular necrosis, it's an anti-inflammatory, but it works as an atrophitic agent to the tissues. It makes no sense if you're treating a chronic tendonitis or a tendon that won't heal or a chronic inflammatory joint. It makes no sense to inject an atrophitic agent and expect a trophic response. If you want a trophic response, if you want healing and healthier tissue, you need to inject a trophic agent. Steroids are never going to be that, and they can't, right? The only trophic agents you can have are things that help you heal, that change the health of the tissue, that change the health of the joint. Atrophitic agents are never going to be that. When we talk about Achilles tendon injuries, we just had a study published, and even and the only argument against autologous cells is some people's bone marrow is just crummy, right? Well, even in a 56-year-old, and I use the analogy all the time of an alcoholic, mainly because I'm from Texas, right? So it's not, and Texas and Florida are a lot alike. It's not like speaking up in Minnesota or Massachusetts where they don't allow guns or drinking. Yeah, certainly not at the same time. This is the study I was talking about steroids in the Fabini article. Peer booms. Even PRP give better results than steroids and joint injections. Delayed unions, non-unions. Here we go, the Achilles tendon injury. What I was going to say is, even if an alcoholic has a drink, they don't see much of a difference. But if someone that's never had a drink of alcohol has a drink of alcohol, you see a profound response, okay? In people that are elderly, they're not used to seeing circulating mesenchymal stem cell levels. They're not seeing aplastic mesenchymal stem cells in the circulation. Any trophic response is possible because their body hasn't seen that level. It doesn't take the same level of cells to provoke a healing response in someone that's used to seeing none, right? And there's a good study published where they actually measure aplastic circulating mesenchymal stem cells after a hip fracture, after an ankle fracture, and after a total hip. The body knows and can mobilize cells from its own bone marrow, and this is in octogenarians, okay, people over the age of 80. There's a 20% difference in circulating mesenchymal stem cell difference with a hip fracture and an ankle fracture. There's almost no circulating increase in mesenchymal stem cells after a total hip because the body's not trying to heal a total hip. You're provoking, it's not the same response. It's not that innate trauma that a hip fracture gets. A hip fracture will provoke a circulating stem cell response by over 20%. An ankle fracture gives a little bit lower than that, and a total hip doesn't really make any difference at all. So what that means is in those 80-year-old people, their body's still working hard to promote some circulating exogenous response to the trauma from their own bone marrow. They're still liberating those own cells, because it makes a difference in their ability to heal that fracture. It's how the body sees the trauma. We're not trying to change the pathophysiology of the human body at all. This is how wounds already heal. Right? You need Wnt4. If you don't have Wnt4 as a protein, you can't heal a wound. Okay? Guess where Wnt4 secretion stops from? Hematopoietic stem cell secretion into the wound, provoked by a mesenchymal stem cell response. We don't even teach that in the textbooks, right? You can't see HSCs as part of wound healing, but that's where Wnt4 comes from. That's where PGE2. Without PGE2, without prostaglandin secretion, there's no angiogenesis. Without angiogenesis, there's no wound healing, right? So we kind of need to back up with how we're looking at this and realize that the body already has this amazingly homeostatic organism that's trying to achieve homeostasis and heal things. We're just trying to help. The Achilles tendon we injected this lady was 56. It was a one injection, 10-year-old lesion, who a competitive tennis player back in the day. 10-year lesion, didn't want to have surgery, been to doctors in 3 different continents. She was English. We did one bone marrow aspirate concentrate injection in the Achilles tendon. 80% on RGI units, meaning on MRI. There's an 80% healing response at 10 weeks. The patient was completely asymptomatic, playing tennis again. The next time I got to see her, she was 32 weeks out. On the MRI of the tendon, and this is already published in Cell R4, it's a stem cell journal, but at 32 weeks, which is next time I got to see her, the soft tissues of the Achilles tendon that had been ruptured for 10 years in a 56-year-old female with one bone marrow injection, no big open surgery, no big wound that has trouble healing, one injection, the RGI, meaning on MRI, homogeneity of the tendon, no echogenicity, no scar, no fibrosis. The echogenicity of the tendon is exactly the same of all the other normal tendons and ligaments of the foot and ankle, with just a stem cell injection in the Achilles tendon. So even in a 56-year-old, 56-year-old bone marrow is not 20-year-old bone marrow. But that response is possible because the tissue hadn't seen any of that. These studies are already published. That's what it always cracks me up when some guy says, well, I need white paper on this. Look, everyone in here has seen microfracture surgery, right? One of the more common cartilaginous surgeries that we do has the worst literature supporting it of any of the fractures we do for cartilage repair, because it really doesn't make a big difference for people. A lot of people go to avascular necrosis, a lot of lesions don't heal. If you look at the largest review paper ever published on microfracture, it says more data is needed. It's inconclusive. It's still the most common surgery we do for cartilaginous replacement. There are studies already published in humans, sheep, rabbits, equine. We can promote chondrogenesis in a treated knee better than a non-treated knee with biologics at the time of surgery. This stuff's been published. Some of this is 10-year-old data. Joint replacement. The only study published, and I love this because someone will always bring up this study on pure booms. The only study published to show that the use of biologics didn't make a difference in the patient is a study by pure booms where they took PRP, and at the time of surgery, they were trying to show that it made a difference in swelling and pain. But all they did at the end of the case is they injected into the gutters around a total knee. Does the pain of a total knee come from the gutters after joint replacement? No. The pain from the knee comes from the anterior healing of the quad, the infrapatellar tendon, the inflammatory response by pulling the patella out of the way, right? So if you really want to change the healing of pain of a total knee, inject the anterior quad and the infrapatellar tendon. You don't squirt it in the gutters. So the goal of their study was to treat pain and swelling, but they didn't treat what causes pain and swelling after a total. And so, I mean, you're not going to see a difference if you're looking at the wrong thing. This is how we do a total, right? You inject the quad because you're going to see a difference in augmentation at the healing of a very avascular area of the VMO, and you inject the infrapatellar tendon. And the anterior knee pain, the extension lag, the amount of swelling and pain you see after surgery is dramatically different. But you have to have a goal to what you're doing. You can't just squirt it somewhere. ACL reconstructions. We talked about this study last year when we were working with Dr. Heckman and Dr. Andrews when we were going through some of the data. The first time we ever talked to Dr. Andrews, going through basically an iPad of about 80 ACLs in a row. Our ACLs are somewhere between 16 and 24 weeks, showing complete homogeneity of the tendon. I don't use autograft anymore. The only argument for autograft in our practice was that it heals faster. We've removed that as an argument because we've taken Achilles tendon allograft and at 16 to 24 weeks showed homogeneity of the tendon for the last 3 years. So if you can take biologics and lower the morbidity of the surgery and change the healing time, now you're promoting an allograft tendon to heal in a shorter amount of time with no harvest morbidity, no patella tendon fractures, no patella fractures, no infrapatellar tendon ruptures. Honestly, and I make the argument all the time, and I know how you guys do it here is different, but I make the argument all the time, if a patient walked into my clinic with the middle third of his patella missing and the middle third of his tendon missing, and says that their knee hurt, I would be compelled to try to fix that. So, well, what kind of graft could I use to help rebuild the infrapatellar tendon? Our goal is to take, and the other part of this, and there's a good study already published, and all they did is use PRP, and they took a 50% difference in the healing time, and you guys know how this works. This is perfect in a big group of people, surgery personnel, instead of necessarily a big group of surgeons. Is for the control group, there's 4 guys in the group, 2 guys are younger, they used PRP, the 2 older guys didn't use any biologics, and then they just compared their study. And the guys that used no biologics, about 369 days to healing of the graft. The guys that were using PRP, about 179 days. And the MRIs associated with that study are dramatic. If you do an MRI after 6-8 weeks after a knee scope even, it looks like a bomb went off in there. There's echogenicity everywhere, there's bony edema. You can change that with the use of biologics when you look at some of these MRIs, and we'll show you some of those. We also are looking at the difference between proximal tibia draw and iliac crest, and we kind of know the answer to that already. Hopefully you guys have seen the biomech already. It's just a draw from proximal tibia. So what we're trying to do is lower the morbidity of the harvest, right? The way to increase the use of autologous biologics is make it where Joe Blow guy can do it. You don't have to be at the Andrews Institute to have some guy take your iliac crest draw, right? The reason I developed the catheter as an anterior iliac crest draw is because I'm fellowship trained in trauma. In the middle of the night, I had to put in a lot of anterior pelvic pins, right? We're putting on a lot of frames. I mean, I did my trauma fellowship in the late 90s, so a little while ago. And we had to put a lot of pelvic external fixation devices in without having a lot of time for C-arm and waiting for a CT guided placement and that kind of stuff. You fill the crest, put a pin in, and put a frame on. Well, if you can fill the crest, you could get access to bone marrow. The problem is with the jam sheeting and a mallet, those people would hurt forever because you're getting a and here's the way I want to explain this. When you use a jam sheeting and a mallet, it's like a rock hitting the windshield, right? There's a hole there, but there's also all these little spider webs of fracture lines around that. Those spider webs of fracture lines bleed, right? Fractures bleed. Bone is covered with the periosteal sheath. So now you have something bleeding underneath the periosteal sheath. The only place the periosteal sheath has been invaded is where you put your hole, right? So blood from the hole won't cause pain. It'll leak into soft tissues, it clots off, it stops. Blood underneath the periosteal sheath causes pain. So you get a periosteal, subperiosteal hematoma. Those patients hurt for 6 months, and it shows up on MRI. You see this big inflamed subperiosteal hematoma. Even on iliac crest, and iliac crest does it less than all the other bones, but like a proximal tibia or a proximal humerus, a subperiosteal hematoma, go all the way down the medial face. It's just one compartment of periosteum, right? So you see these patients that are tender to palpation over the shin for months, and you caused it. Because when you pop that catheter in or use the jam sheety, you would get fracturing around that hole. And the analogy I use all the time is at a dinner table usually, right? We do a lot of in-office draws. Matter of fact, 90% of our follow-up injections are done in the clinic, okay? And I've done my mom. My mom's 72 years old, won't have a total knee because my dad had a stroke, and she's the only person that can ever take care of him, apparently. And so we've injected her knees over the last 4 or 5 years, probably 3 or 4 times in the clinic. If I take a mallet and hit a table, the whole table vibrates. Every glass of water on the table will vibrate, right? If I take a drill and drill a hole from it, nothing else vibrates. I can block with a little lidocaine where I'm going to drill a hole. You can't block the whole iliac crest or the whole proximal tibia. So the reason you can't do an in-office draw with the jam sheety is because it hurts, and because you're fracturing, and because it's impaction. It's not just pressure, right? Putting a drill hole in a tibia, the morbidity is nothing. 3 days later, you can percuss over this injury. It doesn't hurt. I've done it to me, right? So, but jamming a jam sheeting in there, the difference is it looks like a bomb went off. There's fracture lines all around it, and it worsens over time, not gets better, right? These fracture lines extend. So this is ACL graft, 12 weeks of bone marrow, right? Homogeneity of the tendon already, the edema around the knee doesn't look like a patient that had a scope. It was a series of 80 of them, right? This is only 12 weeks, so it's not complete homogeneity of the graft. We would not judge this as healed. We would judge that as healed, right? So they look at what's called RGI, or intensity units, relative intensity units. This is a 6-month-old graft without biologics. See the difference just in how the knee looks, the inflammatory response, and this is already out of a paper that's been published. The graft doesn't look healed. The graft doesn't even look present, right? It's there, but it doesn't show the same homogeneity on MRI until you get 12 months out, 369 days. This is the reason we do ACLs, right? That we're trying to prevent this. So an unstable knee, and I'm just a little Texas boy, so my analogy all the time is if you knock a tire out of line just a little bit, it wears out faster, right? So you drive on a tire that's wiggling around a little bit, pretty soon there's not a lot of tread left. The same way with your knee, if you lose the anterior lateral stabilization of an ACL, it doesn't mean you can't put a brace on it. It doesn't mean you're going to hurt forever, but it means this happens faster, right? You see our cartilaginous wear and tear. That's someone's ACL. There's after we clean it out the tunnel. There's our graft. There's the needle into the graft. So what we do is we'll suck all the water out through the scope, put the needle up into the tunnel proximally, up into the tunnel distally. And again, it's not, remember what we said? This is a key point going back to earlier. It's not about making those cells stay in my graft, right? The physiologic volume of the knee is 5 to 7 milliliters. We're going to change the physiologic volume of the knee with something that's better for it. When you scope a knee and you take the inflammatory fluid out, you're removing matrix metalloproteases, you're changing cytokines, you're changing the pH, right? All that stuff is bad. It's all cytodestructive. It destroys the cells, it destroys, and it builds up, right? Methyl metalloproteases are one of those things that, matrix metalloproteases, you really need to kind of start the cartilaginous wear so you can fill it in with some healing, but you need to be able to turn it off. And sometimes they can't downregulate. The cytokines, the inflammatory cycle can't downregulate. Bone marrow superconcentrate, the way to think about a stem cell is a really, really great autologous anti-inflammatory cell. It's going to secrete things that bring you back to a homogeneity, the body's ability to achieve that homeostatic point, right? So this is just the common clinical uses what we're so far. A lot of non-union fractures, and honestly, spine fusions. If a guy is doing spine fusions in the lateral gutter and not using autologous cells, he just hasn't read. It's the most and everyone that works in the hospital knows why. It's because there's so much money in spine that those guys were able to use a lot more of it, and it didn't affect the hospital's bottom line as much, right? So using an extra $2,000 kit for a spine fusion didn't matter as much as if you could get them to stop using $10,000 a dose BMP, or just cut their BMP doses in half. So all that stuff's been published. So there's actually studies showing that autogenous iliac crest on a fusion on one side is the same as calcium pyrophosphate, which is the worst graft known to man, with bone marrow superconcentrate. The fusion rate's the same. The morbidity is grossly different, right? Iliac crest graft harvest patients hurt. Calcium pyrophosphate patients don't. Bone marrow doesn't hurt, right? So now we have a fusion rate that we can show, published on one side, that bone marrow superconcentrate's equal to, they can take the worst graft known to man and make it equal to autogenous iliac crest. Pediatric study out of Delaware, where they did scoliosis cases, and they would take rib graft, which is when you can sprinkle rib graft and make bone grow, right? You can almost see it, right? So they took rib graft on one side and synthetic graft with bone marrow on the other. Healing rate's the same, morbidity's lower without the graft harvest, right? Compartment syndrome, talking about angiogenesis, collateral circulation. This goes real well into a lot of the heart studies that are being published right now. Taking the anterior tibial compartment from blast injuries, it's basically dead tissue, but the collagen matrix is there, right? The trellis is still on the wall, but the vine's dead. All we want to do is repopulate the cellular volume, and we've been able to restore function, electromyographic function, even of some of those dead compartments. And the rotator cuff injuries in elderly and immunocompromised. I tell people all the time, where bone marrow can help you a lot is in your bad patients. And just because someone's old and has bad diabetes doesn't mean that they're a bad patient, but it means their tissue is really crummy. And if you've gone back in on any of these rotator cuffs, it's like operating on white, dead piece of skin, right? There's no cellular volume in it. There's no contractility left. It doesn't look like muscle. It looks like the consistency of a cue ball in some of these people, only it's soft and it's macerated and you can't even really get it told to stitch. What we're trying to do with bone marrow is repopulate in a cellular level that tissue, help keep the tissue healthier. That's where you see the biggest difference. So here's what we talk about all the time. Because is bone marrow the only answer for your stem cell patients? No. There's some really, in Panama, Dr. Reardon uses cultured umbilical cells, which would get him absolutely thrown in jail in the United States. Because we can't use the umbilical cord. We can use the amniotic membrane, but we can't culturally expand those cells. I can't take your bone marrow and hold it in the lab for 5 days at the right temperature and the right environment and then give it back to you. If I take your bone marrow in the US, I have to give it to you within that day, the day of service, the time of service, right? What would be way better is if I could take your bone marrow, culture it for about a week, add umbilical cells to it, culturally expand it, get rid of the bad cells, separate only the good cells, let those expand another week, and then inject your tendon. We can't do that in the US right now. So what are our options right now to help you heal and lower your infection rate? And we actually are getting ready to publish a study where we're seeing you actually see zones of inhibition around the mesenchymal cell, right? So there's a study published in California where LL37 is a protein, one of those secretome proteins, right? It's a peptide secreted by the cell that is the most potent bactericidal the human body can produce. So the reason our infection rate in the stem cell study is so low is because the body is protecting itself. LL37 is secreted by these cells at a level to be cytoprotective. So in a cultured lab environment, if the cells are, if a culture got contaminated, we would literally see zones of inhibition, almost like you'd put an antibiotic disc in the middle. And they actually treated nosocomial-induced pneumonias in rats with nothing more than bone marrow aspirate concentrate and cured the rats, right? Because of the secretion of the protein. So what we're trying to do is take something that's easy, cheap. That's the whole reason we invented the catheter, because now you don't have to be a trauma surgeon to not be afraid of an iliac crest draw or a proximal tibia draw or a proximal humerus draw, right? Old versus new. I always laugh because it looks like that's going to be really easy until you figure out it has 50 steps. So this is the difference in the catheter. What we're trying to do is make it where you don't get platelet cell activation. I talked to one of your nurses here earlier. It is, having done cell counts on hundreds of consecutive draws, it's really easy to do a bad draw. It's really easy to do a bad draw even using my device. If you do it wrong, if you do it right, we've tried to make it where you can get the best draw possible. And the best draw possible is defined as not a lot of clots and higher cell volume, right? So we do cell counts on a bunch of consecutive draws. Little things that you do made a huge difference. Changing the design of the catheter, making these cuts radial, and so we get rid of some of the sharp edges when you start pulling through the catheter. Adding that plunger, so we get about an extra centimeter and a half to 2 centimeters distal to the tip of your catheter. So now instead of trying to drink from running water, you're drinking from a lipid pool, right? So the pool of cells that you're drawing from is already there because you've kind of fractured into the cortex below that. Not just taking an autovac and pulling it all the way out and being really violent. The goal of a bone marrow draw is a higher cell count, not just to get it over with, right? So if you get in and you're really violent with the draw, you get platelet cell activation, your cell count is going to go down. And you can see a 30% difference with little subtle change. Not making an incision in the skin, not making a little poke hole in the skin, just taking the catheter, because I have a spine guy that's one of my dear friends, but he just takes the catheter and puts it in the skin and drives it in. About a 30% difference in cell count. Because you see platelet cell activation, because of the little bit of debris that the skin and the subcutaneous tissue doesn't want to be there, and you see a little bit of platelet cell activation. Platelet cell activation causes clots, clots lowers your cell count, right? So just doing that one little thing, and if everything we're doing is about getting better cell counts, and if the only argument against bone marrow is cell counts and the bioavailability and people that are immunocompromised already, why not do every little thing we can to get the best cell counts available, right? Make a poke hole in the skin. Don't just pop it in without using a drill, right? Don't put a big syringe on it. Don't use don't use a 120 cc syringe and pull the thing all the way out, right? It's a very violent draw. You watch it bubble into the syringe, it's trying desperately to get in there. Slow, methodical drills, slow, methodical draws increase your cell counts. The whole reason we've done all these little things with the catheter is just to try to give you a better cell count. See how much you just grab the iliac crest and you just move it over a little bit. It doesn't, and if I can do that with you awake, and you're not real, if I can move that skin over with you awake just by bumping up your hip, this is a really easy procedure to do even with you awake. So 1% lidocaine, inject over that crest after I move that tissue, make a little poke hole drill, and I can talk to you the whole time. Go through my little drill spot, isolate the crest where I want it. And it should look really easy, right? If it looked like your guy's struggling, he is, right? So if you're struggling and you're just pull back, make a different incision, change crest, do something because you want better cell counts. Just stick a little plunger. Most of the time now, I don't even use the plunger first. I'll hook the syringe first to it and just see how easy it is to draw. But you can see if you use that little plunger, I mean, it just starts coming up. So there's not a lot, it's not a violent draw. And it takes about 3 minutes. So it's not something that should delay the case. Or now, I'll actually prep that hip into the same field as the knee. And here's what I tell people all the time. If someone's paying cash and I'm really worried about they're paying cash for the stem cell volume and I'm really worried about the lesion, I'll still draw iliac crest. If I'm not that worried or if they're younger, I'll do a lot of proximal tibia draws within the field already. Proximal tibia draw is about 70% of an iliac crest draw. Proximal humeral draw is a little bit less than that. A distal femur draw is about 10 to 20% better than a proximal tibia draw. But the best is a vertebral body or an iliac crest. And here's the other thing to think about, and this is an important point, and you guys will get it. What is the volume of an iliac crest? Is it 200 cc's? You guys have seen an iliac crest, there's nothing in it, right? It holds 20 cc's maybe, right? Why are we drawing 60? You see guys drawing 400 cc's of volume. After the first 90 to 120 cc's, they're drawing whole blood, right? All you're doing is causing retrograde blood flow. That's one of the reasons we designed the catheter the way we do. We want it to kind of get a nice fit so you can cause retrograde blood flow. A mesenchymal stem cell is called an aplastic adherent cell. They want to stay where they're at. They don't want to be mobilized in response to trauma. They certainly don't want to be mobilized in response to you wanting to do someone's ACL, right? So that adherent aplastic cell needs to be mobilized into our syringe. We're washing these cells. When we draw 60 cc's of bone marrow from the iliac crest, it's not because that 60 cc's was there. It's because we're washing those cells into our syringe, right? The first 30 cc syringe you have is the best. The second 30 cc syringe you have is pretty good. The third one is okay. By about the fourth, you're whole blood, which is, again, okay if you need more volume. Spinning down whole blood gives you really good quality growth factors, right? That's what PRP is. But if you want really high cellular volume, that first 60 cc's is the money, right? After that, 400 cc's, I don't care how much you pull, how much you want to spin at one time, it's not the same. I mean, and you know that already because there's not 400 cc's of bone marrow in your hip. It's whole blood that you're causing a retrograde blood flow in, right? Same with proximal tibia or proximal humerus or distal femur. A little bit more bone marrow in the distal femur, but the cell count's lower, right? And again, the only other argument against bone marrow is people that are immunocompromised or old, right? Elderly, right? But with exposure to membrane proteins from an amniotic membrane, you can get the metabolic activity of those cells back. And there's good studies published that say old cells in a young cell environment respond like a young cell. When you see some of these 60-year-old bad diabetic patient, right? Which a 60-year-old bad diabetic is like an 80-year-old healthy person, right? Because the immunocompromised effect of diabetes, what it does to your stem cells is profound. All the receptors go away. You look at them under a microscope and there's no cell receptors, there's no mitochondrial changes. You have trouble differentiating it without a stain on what kind of MSC it is, right? Well, by exposure to the amniotic proteins, transmembranous, we've been able to take 80-year-old cells and give them the metabolic activity of a 25-year-old. So now all the arguments we had against autologous bone marrow are starting to kind of go away, right? You can't get the same cell counts. Well, yeah, you can if you pay attention. Well, but you know, in people that are immunocompromised, their bone marrow is crummy. Yeah, well, use amniotic membrane proteins with it, right? And not some of the just amniotic liquid. I mean, a membrane. I mean, a morselized graft, an injectable patch that actually has transmembranous proteins. Not, you know, I hate to say, I won't say the name of the competition, but someone that has like 125 micrograms of crushed up DNA that's, you know, been beat up. I think I'll probably talk long enough. Kind of get where I'm going with the bone marrow volume of stuff, the fact that it's not about the cells becoming something else, it's about what they secrete, about in the different clinical uses for bone marrow in your head, about wound healing. Without Wnt4, without PGE2, things don't heal as fast. If I could do anything to give you Wnt4 and PGE2, it would make sense, right? I tell people all the time, look, if pixie dust made a difference, I'd use it, right? And now I have your cells concentrated from you with a side effect low. Okay, one of the greatest lectures as a medical student, I remember very little from being a medical student, what the lectures I sat through affected my clinical practice very little at this time. But one of the best lectures I ever sat through was a guy coming in and he pulled out a book and he read the complications of this drug. He said, this is one of the most commonly given drugs in the US. This is the complications of that drug, and I want everyone to know what they're doing to people when you tell people to take this. Liver failure, hepatitis, the most common drug for suicide. And I was just like, oh my God, I'm never giving this to someone. I get my pen out, I'm gonna write it down. It was Tylenol, right? So it's safer than Tylenol because you're never gonna get liver failure with autologous stem cells, right? You're gonna lower someone's infection rate with autologous stem cells. You're not gonna cause hepatitis with autologous stem cells. So now you have a cheap product with a very low complication rate that you're actually changing someone's infection rate. So just want to change the thinking a little bit about what you're doing because you guys are the front line, right? Proximal tibia draws are easy, but it's not as good. But it's really easy if you do it right. Do you still get 60 cc's of cells and still get a really good quality of aspirate and look, we all know, and you guys this is what used to kill PRP, especially in office. You'd have someone pay to have a PRP draw and come to clinic and there's like drawing blood from a turnip, right? And I'm an orthopedic surgeon. If you call me to come start your IV, you're gonna do a vein cut down. I'm gonna open your ankle, right? But you know what every orthopedic surgeon can find? Medial face of a tibia. So if I have a patient come in for a draw to the office, you know what I'm always gonna get? Bone marrow from a medial face of a tibia. You know what I may not be able to get? A 60 cc blood draw with that 10 gauge we give you, right? You get that big needle and you're trying to find the vein and you're trying to get 60 cc's and you've stuck someone 4 or 5 times and you're getting frustrated and the surgeon's looking at the clock and PRP's harder to use. Give me a catheter and a medial face of a tibia, I'm gonna hand you 60 cc's and we can get started. And it's better. And it has active cells. And I have higher Wnt4 and PGE2 secretion. So, you guys have all done that.
What's the time frame we should be shooting for to inject? Like, draw in the beginning of the case,
It's
should we within 2 hours?
no, it's the same. Now you may get some clotting and loose, but you're not going to change the biologic activity of the cells. Don't change for. And Brian Barnes is the best person in the world to ask on that because he's probably studied it more than anybody in the country. But as long it can sit on your back table for 6 hours and still be about the same as it was when you pulled it. Anything? Huh? Yeah. Yeah, but you won't hear you okay on the video.
Yeah. So you have that 6 to 8 hour window for PRP would be that way, and for marrow. The real challenge is this: the longer it sits there, and if it's not being mobilized, meaning if it's not rocking, you'll start to see clots form. And you need to think of it kind of like a forest fire type of event. If you get a little bit of cell activation and it sits quietly, it's going to go through and it's going to start to create that forest fire effect where you're going to see activation. Now, cells can actually activate, then they can calm down, and that will happen over time. But the ideal situation is if you're going to let it sit, keep it moving, keep it rocking. Absolutely, before you concentrate anything, make sure it's rocked a few times back and forth to get that nice homogeneous spread of all the cells across that tube. And then, filtering out, especially with bone marrow, filtering out any of the clots is a huge advantage. You get rid of anything that could continue that activation down the line, and also it helps with the processing of that product.
See, I told you he was really smart. I tell people all the time, and especially when you go to some of these big conferences, I'm just a clinical guy. I'm an orthopedic surgeon, right? I'm a fellowship-trained trauma guy, so I'm even like more of a clinical guy. I don't, it's about the, pre-op planning and making ugly pictures pretty with the x-rays. But you go to some of these meetings, and there's guys who've been studying this stuff, the cellular metabolized protein of LL37 for 20 years, but they haven't treated a patient. And, they're doing rat studies still. So you guys are way ahead of that.
No questions, last question.
Yeah.
With so much research out there, with so much research out there, and as long as this has been studied, why are we still fighting insurance companies if you are seeing such wonderful clinical results like we are just for a simple payment?
Yeah, I will. You know what? I think, and boy, if you ask Neil this question, it gets really violent really quick. Because when you talk about, if you look at what they're doing with even MS, with cultured umbilical cells, they're taking people from stage 3 to stage 1 for $20,000. And the average cost of that patient treated in the U.S. is $190,000 a year, right? I don't know. I mean, it's not controversial, right? It's not fetal cells. We've never used fetal cells for research. We're talking about a $2,000 kit cost on most of these patients, sometimes less, right? And we're lowering the infection rate. We're changing the time to healing. So now we have MRIs that show rapidity of healing of a tendon that never looked like that. And I don't even, and look, I'm a busy surgeon, right? So it's not that I'm trying to make myself obsolete with a shot, but opening an Achilles tendon and all the trouble you go through, and you look at that on MRI a year later and it still shows all this fibrosis within it, and it doesn't look healthy and it doesn't look normal, and you're trying to decide whether to let the athlete run and cut on an Achilles tendon that just, you reconstructed to the best of your ability, but on MRI it just doesn't look right. When I can just stick a needle in there and put cells in there and all of a sudden it looks healthy on MRI within 3 months, I don't know on the payer group side, right? Because those patients don't get infected. They don't fail. I'm not redoing a lot of these ACLs because the time that these ACLs fail is, you guys already know, right? The patient starts feeling pretty good. They're at 4 to 6 months. It's not revascularized yet. It's not healed yet. It still looks really crummy on MRI. You saw what a 6-month MRI of a graft looks like. And that patient's like, oh, this feels good. And they're jacking around with some friends on a basketball court, and they cut and they feel a pop. And now you've already used the middle third. Now you're talking about the other knee or hamstring, which you guys already know is not the same, or allograft, which here is one of the great evils, And we just don't have that happen because you're seeing so much quicker incorporation of the graft. You would think from an insurance study, but I'm going to lower your complication rate. I'm going to get rid of the cost of infections. I'm going to get you back on the field. See, that what happens is we haven't done a bunch. Work comp in Texas, actually for work comp for lateral condylitis now, you have to give a PRP injection before you take the patient to surgery, and they have to fail, right? Because we've done some good cost analysis of that for the TWIC for work comp in Texas, and they understand the cost of that PRP injection is about $595. The hospital charge for a partial lateral condylectomy and tendon revision is about $10,000, right? So now to get that patient to surgery, they have to have failed a PRP injection, right?
Dr. McKenna,
So-
you might add something to this because I
Yeah.
think so. I've been involved with CMS on the wound care side of it, and they've recently issued it's called a CED, it's a coverage with evidence development, and essentially regenerative medicine, specifically on biologics, started off in a hole. meaning that there was no consistency in the way they were processed, the way the product was designed, or produced. So therefore, the study designs did not support some of the consistency in the literature. We're starting to get to that point now. Going back to what I said about the CED, that was for wound care, for diabetic foot ulcers, pressure ulcers, venostasis ulcers. CMS is now on board with that. They've just issued the CED, and they're reimbursing for those procedures as long as they're in a research setting. But what got to that point was the body of evidence finally caught up to where the anecdotal clinical evidence was. And I think what we'll see in the near future, we've been in front of CMS for acute wounds already, and they're a little different than something like workman's comp, where they know they're going to own the patient forever and they're going to keep paying for it. Medicare and Medicaid reimbursement, or CMS reimbursement, is really focusing on patient outcomes. If you bring a cost analysis to them, they'll say, I don't care about that. They do, but they have to play the political line and say, I don't care about that. So the endpoint measurements have to line up, and I think that we're getting closer and we're getting better at understanding what those endpoint measurements need to be so the evidence can catch up. I anticipate that what we'll see is surgical wounds. Acute wounds will be the next on that, and that will include burns, like sternotomies will be a real focus for them. And then I think what we'll start to see is some of these soft tissue treatments will catch up from that. But the really powerful thing is when institutions like the Andrews Institute get behind this, they have the ability to start cranking out some of this data that will be hugely supportive for getting reimbursement eventually.
When you talk, here's the other thing: the market right now is patient driven, right? I tell people all the time, and my wife is gonna hate it when I say this out loud because she's heard me say it for so long. But I tell people all the time, I'm just a small country doc trying to eke out a living, right? And in Decatur, Texas, last year, we did people from 13 countries and like 15 states. And the reason we did that is because people's doctor saw me speak in the Bahamas, or he read something I wrote with Dr. Reardon, and they want autologous stem cells used. And they pay cash for the kit, right? It's just like bringing their own brace. And here's how I did it with the hospital, right? Because I'm also a hospital guy, and I work at a small facility that I'm a big part of their volume. And so I can't just make them take the hit all the time. Sometimes I do. Sometimes they just have to eat it with me, right? But most of the time what we'll do is the patient pays for the kit, just like they're bringing their own brace, or just like they're doing their own VenaPro, or just like they're doing that, and then we use their kit. So instead of the hospital charging $7,800 for a bone marrow kit that cost them $1,600, right? We'll let the patient pay $2,000 for the kit, or $2,500 for the kit, and they bring that kit and we use their kit. And the hospital doesn't get hit. The patient gets the stem cells that they wanted in part of their surgery, and it's kind of a cost savings for everybody, because that same kit, and we designed it, right? I mean, the catheter is ours. I mean, the bone marrow being drawn in wounds, we have almost 5,000 cases now, right? So we've been doing this for a long time and on a lot of people. But there are a lot of places using my kit and charging people $5,000, you know, $7,000, $10,000 to use your own bone marrow. It's like, really? You know, I mean, I get it, yes, but I'm just trying to augment surgical results still, right? I'm not trying to provide some magic key. I'm just trying to get you to heal your ACL faster, get you to not come into my clinic with a 10-year-old Achilles tendon lesion, getting you to inject your elbow and get you back to work, you know? Treat a wound that someone sent me from someone's great grandfather's whatever that won't heal. Getting a rotator cuff tissue to heal that in someone that's, you know, diabetic. So we have a unique opportunity in the small practice to be able to, you know, very busily apply what the patients are asking for. So most of it, I think, is going to be patient driven, the same way the AARP drove where secondary insurance is, right? Patients finally demanded it and they got their way. So, but cost of reimbursement, what I was saying about work comp earlier, is work comp figured out that the amount of time that patient out of work is part of the cost benefit analysis of this, right? The amount of time an athlete misses the field, it's a huge deal to him, right? And if you can lower all that, then you've tilted the cost to your favor. So. But again, CMS doesn't include any of that. Time lost off work. Anything from a science standpoint while Brian's still here? No. All right. Thank you guys for your
One more
attention.
question.
Yeah.
Can you talk just a little bit about can you talk just a little bit about the uses for the platelet-poor plasma, the benefits of that?
Yeah, and I skipped over that slide too, right? Did you see that slide? We use platelet poor, it's basically fibrin glue, right? I mean, the proteins in PPP are real and viable and very useful. And I'll tell you the clinical story, because I tell people all the time that, you know, when I do that little poor country doctor trying to eke out a living thing, is I may just give anecdotal information, but it's 5,000 cases, and I'm pretty consistent in the way I do stuff. So I know exactly, and I follow up on it's me and 2 PAs. So I know how all my patients do, and I follow them all up, and I get to see them. And with PPP, how it evolved with the use of PRP is about 10 years ago, right? 7 years ago. We're like, I don't know. I'm reading all the growth factor stuff, and we're looking at VEGF and fibroblastic growth factor and transforming growth factor beta, and we're looking at all these concentration levels. I mean, all this makes so much sense. Let's do. We got 10 knee scopes on Monday. Let's do it at 5 and not 5, and let's see how they do. And Friday, you and I, the PA with me at the time, we'll see if we can not. We'll just randomize it, and we'll see if we can pick the ones we did PRP on, just by examining the knee. We were both 5 for 5. It's like, no. There's no way. Let's do that again. Only this time, 5 for 5. So, okay, we're using PRP on all our knee scopes. And then we're talking about PPP, and we're talking to Brian, actually. And we're talking about backfilling your portals, get rid of some of the synovial reaction and the leakage and some of the soft tissue inflammatory change around. Because remember what we said, these is just an anti-inflammatory, right? And I said, well, let's just backfill all the lateral portals and see if there's a difference between the lateral portal and medial portal. So over a couple of weeks, we backfill all the lateral portals, and all the lateral portals look great, and all the medial portals look kind of macerated and kind of red and a little leaky. It's like, He said, you know what? It's because the vascular supply of the lateral portal is not the same. The medial portal is more vascular. Let's backfill all the medial portals. We backfill all the medial portals look great. The lateral portals look a little shabby. I was like, we'll just backfill all the portals. So if you take that same data, when you do the most common surgery to get a synovial tract is not in orthopedics, right? The most common to get a synovial tract in is like partial pancreatectomy done through the scope, right? 100% of those patients get synovial tracking. And that's a significant cost to the patient. They get really sick, and you're going back in and doing repeat surgeries on these people. So all they had to do is they took the omentum, sprayed it with PPP, backfilled their portal, and the paper that they published was it went from 13 out of 13 with a synovial tract to 2 out of 11, right? So just like with I backfilled only the lateral portals, and let's look, and now backfilled the medial portals. Now over the last 7 years, I backfilled both my portals, and I use PPP on my wounds. So what we'll do is we'll actually inject the soft tissue of the wound at the time of closure, and if we have a bunch left over, if I've done 2 or 3 spins on someone for multiple sites, we'll actually soak it right on the wound on the dressing, and when you come in, there's no inflammatory response. You don't get that red halo of tissue around it. It's a pretty significant difference. And you'll see it. It's not one of those things that you have to wait to see what the MRI looks like at 12 weeks, right? Which I hate that stuff because I'm really impatient. We all want to inject the lateral gutters and make your knee pain go away. But that just isn't the way it works, right? But backfilling portals with PPP, no, I don't throw it away ever. It's fibrin glue, it's anti-inflammatory response, it's all the part of the soft tissue we want to help kind of lower your synovial tracking, lower your inflammatory response as part of the wound healing. Remember, everything we're doing, staying with the pathophysiology of the human body, right? There's an inflammatory, pro-inflammatory, remodeling, all the phases of healing. We just want to move to the right of the diagram. We want to get away from the inflammatory response of healing into that remodeling phase faster. That's all we're doing. And the tissue proteins help do that. So we do make them. I was born at the Claremore Indian Health Clinic. We make use of all the animals. That was a great question. I'm sorry. I did skip right through that slide. Any other questions? You guys have been really attentive. Thank you so much. So.